Hi, I'm Kathy Kirkpatrick, and I am going to be sharing today about the implementation of a tiered services model for school intervention. We're going to talk about a study that we have been working on and some lessons that we have learned along the way. Okay, so our learning objectives for today will be to discuss the value of using a validated tool to assess the level of school need for each student, to review an example of implementation of a tiered services model, and to gain some understanding of the implications for staff resources that such a tiered service model might have. And then we're going to explore how using a tiered service model can help us meet the school-related psychosocial standards of care for pediatric cancer patients. Because this is a recorded session, we obviously won't have opportunity for questions and answers or discussion, but my contact information is posted at the end of the PowerPoint, and I will be more than glad to have conversation or answer any questions that you might have if you want to reach out. I thought it would be helpful for you to have a little bit of background about how our program has evolved over time. We have had a well-established school intervention program for quite some time now. It has historically been a universal intervention model, a model that was initially developed to serve only the neuro-oncology patients, but then quickly evolved to include all of oncology and to include consultation services to the hematology side of the division. The team has always been well respected and well received, and so we get a lot of referrals. And there have been efforts along the way to try to expand our staffing, but resources have not been available to do that. So as we sorted through some of that issue about no expansion of staff and yet expanding need, we began to look at our model. We do see disparity in levels of support among groups within our division. We were becoming increasingly concerned about the universal accessibility of services to the oncology side of the division, but the consult-only model to the hematology side. And since funding was not allowing us to expand our staff and we were having increased workloads, we needed to begin to look at a different kind of service model, and one that would be more targeted to higher risk families. We had some issues with that initially. We were somewhat uncomfortable with the idea of withholding valuable services from some families. At a gut level, it was hard to say, how do we go from a Cadillac to a Pinto? How do we whittle down the services that patients might deserve and might need? But part of that, I think, in retrospect, was really just a matter of us addressing our innate need to want to help all of our families to the fullest amount possible. And it just felt like we were going to be giving up some intervention. That hasn't really seemed to be the case overall. So then came along an opportunity for us to collaborate with some peers, our peers from Cincinnati who had developed the BSNI, and I'll talk about that tool some more later, but the needs assessment tool had just been developed, and we were able to use that tool in our setting and look at it as a way to help us implement a tiered intervention model of service. There is some support, obviously, for standardization of intervention services across both a service, a hospital center, and across multiple centers with the development of the psychosocial standards of care. We have some guidelines about how we can and should be providing services to our families in the oncology world. However, there's no clear picture of consistent services or standardized services across pediatric oncology programs. And while we know that every program doesn't have the same need, there should be some consistent provision of basic services and basic supports to meet the standards of care. At the same time, we were beginning to hear more and work more towards focusing on lean healthcare principles, which essentially says we are looking to find a way to provide the right service to the right patient at the right time, and not wasting resources or using resources in a way that was not necessary for a given situation. And so overall, we need to find a cost-effective service model that can be implemented in a variety of settings and can be standardized so that families across the board are receiving compatible or comparable services. So our team at Nationwide Children's Hospital consists of both bedside teachers and school liaisons. Columbus City School District provides teachers for bedside instruction on our inpatient units, and we have 1.5 teachers assigned to the hematology oncology unit to provide bedside teaching for our patients. We also have access to an early childhood teacher who can see our 3 to 5-year-olds on an inpatient basis. And then we have school liaisons that are a dedicated part of the hematology oncology division and are available to any patient served by that division. We currently have 3 full-time liaisons, and we are divided up by teams and diagnoses in the way that we serve families. The teachers and the liaisons really do work as a team, and we work very closely together, but we do have different administration channels, so that can sometimes create a bit of a barrier in terms of fully planning programming, but we are able to work as a team among us irregardless. So this is just to give you an idea of our catchment area where our patients come from. We see patients in all of central and southeastern Ohio. We go all the way up into northwestern Ohio, and we do see routinely patients from parts of West Virginia and sometimes Kentucky. Of course, we do have out-of-state patients and international patients, but we don't provide school intervention services to those patients on any more than a consultation basis. We're fortunate in Ohio to have a lot of high quality pediatric centers, so our catchment area does overlap with Cincinnati and Dayton and Toledo and Akron and Cleveland. We also have centers that are in Ann Arbor, Michigan, or Pittsburgh or Huntington, West Virginia, that are actually closer to some of our families than we are in Columbus, but insurance issues and so forth sometimes determine where those kids can be seen. I think it's also helpful for background's sake, to know that our region is made up of some urban and sprawling suburban areas, but we also have a large number of small towns and rural communities. So we do have a wide variety of settings from which our kiddos come. The school districts are all very different one from the other. And in Ohio, we do have an issue, a concern with disparity in resources amongst or between school districts. We have pretty wide wealth gaps between some school districts. So those are all issues that we have to take into account as part of our reaching out and serving both the families and school districts. So we made a decision in 2018 to change our model of service for the entire division to a tiered service model. We decided that we would use that model to be able to incorporate more comprehensive services for the hematology side of the division. So we, at that point, began using the brief school needs assessment or inventory that was written by our friends in Cincinnati as a part of our school needs assessment. And so for every new patient or consult, we completed the BSNI along as a part of our overall assessment, and then determined what level of intervention would be provided based on the intensity of the needs identified. We did have to do some education of our colleagues up front prior to implementing the new service model. We had to make sure that floor staff, clinic staff, psychosocial team members were aware of the change so that they wouldn't overpromise services for some families. Our colleagues were great and are great at telling families about the support we can provide, but we had to make sure that they were merely introducing the availability of school intervention and not promising particular services. We do know that sometimes it's families who have less need who are most eager to access supports and resources, and sometimes families who have higher need are more hesitant to actually reach out for services. So we needed to prep our peers, our colleagues, to not be sabotaging the tier aspect of the intervention model. So this, the brief school needs inventory was a linchpin for our change to the tiered service model. This is just a couple of quick snapshots. For those of you who have not seen the inventory, there are specific risk questions, and then there is an overall composite score that helps determine whether a patient and their family fall in the low, moderate, or high range for needs or risk. This BSNI was authored and validated, by Megan Elam and Crystal Murphy and Mary Kay Irwin in Cincinnati, and they did validate it on their patient population. So we decided to use it as a standard part of our service going forward. We did modify the BSNI slightly for use at Nationwide Children's. We only use the risk assessment portion of the tool and the determination of the composite score. There is another part of the BSNI that's more geared towards bedside instruction, and we do not use that part. We did develop a flow sheet for EPIC that includes the part of the BSNI that we do use, and we then started using that for all newly diagnosed oncology patients, all new patients to long-term survivorship clinic, and for all of our hematology consults. So once we completed our school needs assessment and we're ready to create a service plan, we moved our model to this tiered intervention plan where all families receive tier 1 services. So everyone receives the basic services, and then as needs escalate, so do the intensity of the services and our assumption would be that there are fewer folks in the high need area, which would need the higher level of service. This is a tiered model that functions in a way very similar to the psychosocial assessment tool that Kazek and her colleagues have created. So for some of you who are familiar with that tool for assessing psychosocial need, this was developed in a very similar way. So when a family is assessed to have low needs or low risk, academic risk, this is the list of services that is on our menu. So we essentially have a menu that has a list of services available at each level of risk. These services are provided across the board to every patient. So every patient would get an initial consult for assessment with the school liaison. They would receive appropriate documentation for school, whether it's home instruction documentation or medical absence paperwork, whatever. And then also the families would be provided with written materials for themselves and for their school that includes resources and guidance related to academic needs. For low risk families, we provide the documentation and the support materials directly to the family and provide some anticipatory guidance about how they can share that information with the child's school. We do not make a commitment to communicate with the child's school, and we do not automatically get a release of information when a family scores in the low risk level, unless there's a specific need that parents ask us to send something specifically to the school or to the teacher. Then we'll get a release. But we do make sure that the family has our contact information in case they have future questions or concerns. For those low need, low risk families, we do not then do a lot of routine, well, none routine follow-up. We rely on the family and on the medical team to alert us if there's a change that needs attention. And then we'll go back and reassess if we need to. But we do not actively follow families who have scored in a low needs level. Then we have families who score at having moderate needs or risk, and for those families, we obtain a release of information so we can communicate directly with the school as needed. We do send a standard email to the school with the patient information and documentation and a list of resources. We provide additional phone consultation or clinic follow-up with the family as needed, and we will provide ongoing phone consultation with the school as needed. We will agree to participate in phone or video meetings with the school if they're needed, and then we do follow these families, but at a little farther distance, to monitor that things are going along smoothly. We rely heavily on our medical team to let us know if there are any concerns that crop up. But we do then also assess the need for school reentry support when it's time for the kiddo to go back into school. So the way that works is when a family has moderate risk or needs, then these services are added to those of the first level, and they get all of those things. And then when we have families who score in that high risk category, we provide more intensive follow-up. So we more deliberately follow those families in clinic and during inpatient stays. We initiate more routine follow-up. We also offer in-person representation at school meetings for those families. And the idea is that this group of families, students, really probably needs more surveillance to make sure that whatever linkages have been initiated or completed, and they will need more frequent contact with both the family and the school to help facilitate a smooth academic progression. So we do have a list on our menu, a list of additional services that we can provide as needed based on the professional opinion of the school liaison at the time of the assessment. So we can provide faculty in services for school staff. We can provide a classroom visit for peer education. We often participate in neuropsychology evaluation feedback sessions with the neuropsychologist and the family so that we can help interpret that information back to the school in a way to support the family if that is necessary. And then bereavement services on an as-needed basis for both the family and the school staff. We do use, in terms of the classroom visits, we used to offer an in-person classroom visit to every single family that had a newly diagnosed patient. We don't do that now. If we feel like the family is, at a low or moderate need level and could deliver the monkey in my chair or could deliver the cancer ed materials to the teacher, and that the teacher or counselor and parents could educate the peers and are comfortable doing that, then we don't automatically make a classroom visit. We make sure that the school staff and or the parents have the resources to do so, but we don't always go. We're also finding that schools are, over the last couple of years, have become a little more hesitant about having outsiders come into the building, and so they prefer their school counselor to be the person who talks to the peers. So we've incorporated that, and then of course with COVID, it's changed everything. We're not going anywhere right now. So we needed to build in a system for changing a level of need when there is some change in the situation. So if there either the family or the medical team or the school identifies some change or some increased need, then we will do a new assessment and reassess need level. So anytime there's a change in medical status, maybe progression, maybe a new finding that's difficult, we would do a new assessment at that point. If there's any newly identified psychosocial or school concerns, we would again do a reassessment. We have noticed that sometimes families need more or less support than we initially thought at the time of diagnosis or initial assessment, and so we need to reassess and relook at what's necessary or what will be provided. So we use the BSNI and do a reassessment to reclassify their service tier when that's necessary. We do see some families move up or down after about 6 months, 6 to 12 months. And so it does make sense too that we would routinely do an assessment, a reassessment for families, maybe when it's time for reentry into school or when treatment has been completed, because sometimes families present as being higher need than they are once the crisis has resolved, or they present as being very stoic and don't share much need until they become overwhelmed with the whole experience of their child's health journey. So now to our research study. We did do a study, or we're still finishing up a study, where we were evaluating the tiered service model as a way to support the academic continuity and school reentry standard of care for children with cancer. The study was approved by our IRB without continuing review, and we were able to enroll 110 patients. We collected data at enrollment and then at 1 year follow-up. Our primary goals of the study were to assess both feasibility of a tiered service system and the acceptability of such a model, and whether that model could be adequately guided by assessment using the BSNI. So we, like I said, standard of care was changed to include this tiered service model at this about 2 months before we started the research study. And the school liaison would assess school needs at the time of diagnosis with an oncology diagnosis, or at the point of entry into long-term survivorship care. So we did the assessment either during the new diagnosis hospitalization or at their first long-term clinic appointment. Assessments included the BSNI to determine the level of academic risk, and then patients were offered enrollment in the study if they had an oncology diagnosis, if they attended a U.S. brick and mortar school, if they spoke either English or Spanish, and as long as they were in K through 12. The process went so that the consult comes to the school liaison, and that was already in place for all newly diagnosed patients. So we just made sure we had a system in place for monitoring all newly enrolled school-age long-term survivorship patients. We would do the assessment, review academic history and current status, and then because we had made the tiered model standard of care for the entire division, there was no difference in care whether a family enrolled in our study or whether they didn't. We did run into a few bumps. We had initially intended to enroll children or students during 2 school years, the school year of 18-19 and school year 19 and 20. But when the pandemic hit and schools were closed in March of 2020, we had to close accrual earlier than we had planned. We are still collecting our final follow-up data from those last patients, and we did find some barriers in collecting follow-up data, particularly after the pandemic and school closure became an issue, but we really didn't have any issue with collecting baseline data. At baseline, we collected demographic information, diagnostic information, academic history. We got some school records and some school climate survey from the child and parent, and some school belonging data that we'll use later to take a look at some questions. But then we, at the 1-year follow-up, we collected satisfaction data from both the families and the medical providers. So the BSNI, like I said before, was already validated by the Cincinnati team, and they used long-term follow-up population to do that. So we really wanted to use this tool in a different setting, so in a different clinic or a different hospital, and we wanted to take a look at the reliable and feasibility with newly diagnosed patients as well as long-term patients. So that was part of the impetus for putting this all together. So again, our original plan was enrollment of 2 school years, but we ran into some bumps at the end of the second school year. There was that interruption of school data collection, but ultimately it's been reconciled and we're getting those records in now. Some follow-up interviews with families were delayed due to difficulties with the pandemic, but we are finishing that up as well. Initial look at the data doesn't seem like those collection bumps made any real difference between the 2 cohorts, the 2 different school years of patients enrolled. So ultimately, the baseline data at least will be valid and useful for us to take a look at. We typically record school year data from July 1st through June 30th of each school year, so that's the time frame that we use. So the other thing I want to mention clearly here is that as I'm sharing with you some of the data that we have started to see, we are looking at comparing year over year from July 1st to December 31st. And I'm doing that because the data for the second half of school year 19-20 were skewed, and obviously we don't have second half data from 2021. So this will just give a more true picture of how the years compare from one to the next. The other point here is that this data is still provisional and preliminary. We're still collecting the final pieces of data and we'll have a lot more analysis to complete, but these are some preliminary findings that I'm going to share with you today. So we had a total of 110 participants enrolled. 50 were enrolled the first year and 60 the second. The first year we got off to a little slower start in the long-term follow-up clinic, so had a fewer than we had anticipated. The second year things were rolling right along, but then again we had to stop 4 months early. So we ended up with 110 participants. 70 of our participants are newly diagnosed patients with an oncology diagnosis, and 40 were new to long-term survivorship clinic. We're coming to long-term survivorship for the first time, and in our institution, patients generally come to long-term survivorship anywhere between 3 to 5 years after they've been off treatment, after they've completed treatment. 46% of our group was female, and 80% were white. I did take a quick look at Ohio stats, and actually we were pretty close in the racial makeup, in that Ohio overall is 81% white, 12% black, and 7% other. So that was pretty close. The female-male distribution is a little off, but because we're closer to 50-50. So this is what the academic risk profile looked like for the 2 groups. And I think that this is very interesting piece of information. The survivorship group were much lower risk or lower need than our newly diagnosed folks. And the survivorship data that we collected matches pretty closely with the population that Cincinnati used to validate their study, the tool. But our newly diagnosed population has a very different distribution. Once all the data is collected, I'm pretty curious to take a look and see if there are differences in whether or not a family scores a 3 versus a 4 or 5 and the risk. So in a low, the composite score would be 1 or 2. Moderate would be 3 to 5, and high would be 6 or greater. So really, with a newly diagnosed patient, it's an almost automatic score of a 3 because it's an acute health event for the child, which is 2 points. And even if they're in the low risk category, they get 1 more point. So they automatically have 3 just by having a child with an acute diagnosis. So I'm very curious to take a look long term to see if there's any differences between the families that scored 3 and those that scored 4 or above, and how many of our families who scored a 3 at diagnosis 6 months or 12 months later, were they still in the moderate range, or had they moved down to a low category once the once the condition was more of a chronic, ongoing situation. So the research questions that we asked as a part of our study were whether or not such a model using the BSNI was feasible, whether there could be fidelity and service provision in terms of did we provide the services that we recommended at tier assignment, was the model acceptable based on parent and provider satisfaction scores, and what did the utilization of resources look like? Did this model, this tiered model, actually have an impact and help us to use our resources more efficiently? So feasibility, certainly all of our patients did receive the assessment, and at an initial consultation, initially we had set a time frame for completion of the assessment and enrollment, but find that there is really fluidity based on diagnosis, setting, family readiness to discuss concerns at length. And so while we did complete the assessment early at the beginning for families, sometimes enrollment was delayed for a month or 2 months because the family just wasn't quite ready to settle in and do the questionnaires for us. Our follow-up at 1 year has been difficult for some families, particularly the lower need families, because we just find that they don't call us back and they just don't see a need for the follow-up. So that has been a little bit tricky, but the baseline data was not difficult to collect. It was certainly feasible from the standpoint of doing the assessment and assigning a level of service. Fidelity of the model is something that is going to be, I think we're going to have a hard time sorting out what was impacted by the pandemic and the fact that we were working from home and schools were closed. Our goal was to certainly see if we were providing the services that we felt were necessary at assessment, but some of those were changed because of the situation with the schools, and that interpretation is going to be complicated, I think. So we may or may not be able to answer that question once we've looked at all of the data. Acceptability was another target that we had, and as we moved from the universal service model to the tiered service model, and we're reducing services for some groups of patients, we felt like it was really important to make sure that we were not losing satisfaction from the change. And so we got surveys from the family and from the provider at the end of the first year. Um, the questions that we asked parents were whether or not they felt that the school liaison was available as needed, whether they had unmet needs related to their child's schooling, and overall satisfaction. And we asked the providers whether they felt like the school liaison was available to them, and overall whether they were satisfied. Um, and what we were looking for is to make sure that the level of satisfaction was comparable across all groups of patients. This is the preliminary data related to that. So the scale here is that 1 is strongly disagree to 4 is strongly agree. And with overall parent satisfaction, we found that there was really no difference between the low needs group and either of the other groups. There was a significant difference between the moderate group and the high group. Moderate group and high group. Although curiously, the high group had a lower level of satisfaction. So what we would have been expecting if there was a problem is that families who receive fewer services, so the low need group, would be less satisfied if this were not acceptable. My part of my thinking is that with the high needs group, there just may be more needs that are not addressed, or that new needs keep cropping up, so that their level of satisfaction might be lower just inherently because they have higher needs. And curiously, the moderate group had the highest score, and it may be that they felt like the most of their concerns were addressed and felt the most impact. There was no difference in the level of identified unmet needs across groups, and no differences in the school liaison being available as needed. For the providers, there was a significant difference between the low need group and the high need group, although again, the difference was skewed in the opposite direction that we would have expected to see if this model was unacceptable. So low needs was the highest, and high need had the lowest overall provider satisfaction. And again, it may very well be a picture where providers see more needs in this group and see more residual need, and so that impacted their satisfaction there. And then having the school liaison available to the provider as needed. There were differences between low and medium, moderate, and differences between low and high. But there were no differences between the moderate and the high group in terms of the availability. So again, probably providers didn't feel like they needed the school liaison much with the low needs families, and they needed them increasingly more with the as the needs increased. And so it may be that they just felt more need and noticed if they couldn't reach somebody right away. But because of the direction of these significant differences, I think we can say that the model is acceptable, because we did not find that folks who received fewer services were any less satisfied with the program than those with higher risk or higher needs. In terms of resource utilization, we wanted to meet the psychosocial standards of care, but we needed to find an efficient way to use our resources to do that. We did not want to limit services to any districts, so we did not want to say, oh, we'll only go 60 miles or 100 miles, because in our catchment area, we have a lot of small rural districts that are, 100 miles away that don't have the resources and needed support more than schools that are 20 miles away. So that was one of our considerations. But we were looking for a reduction in the use of some of our resources, things like mileage, and differences in the use of resources between the service groups to help validate the fact that the tool was identifying the need levels appropriately. So here is a graph that shows some per month statistics that we keep on a regular basis. So this is at the beginning of school year 18-19 is when we started the new model. And these are the 2 years of the study. And then in 2021, we're still getting follow-up data, but we're not enrolling kids. So really, despite the change in model, the number of school meetings that we participated in each month has been stable. The number of counties that we have had kiddos come from has been about the same, and districts has been relatively the same. Districts historically have been in the 40s, about 40 school districts, 45 school districts a month that we interact with, and we keep these stats, just the counties and the districts, more for the hospital to show what kind of outreach and how far our reach is for our families. But the stat that seems to be showing us that we are seeing some benefit from the change is that we saw an increase from 65 patients a month to 78 patients a month, the number of kiddos we could serve. Now, we did hire a third school liaison midway through the 1920 school year. So remember, this is just the first 6 months of the school year. So that of averages that we're looking at today. But the increase from 1920 to 2021 may be more related to the fact that we now have a third liaison than necessarily the directly related to the model, but we are serving more patients. I think this is pretty amazing to look at. This is the number of miles per month that we traveled as school liaisons. The year before we put the tiered model into place, we were driving about 927 miles a month. The first year we put it in place, it was 425. That is like 500 less miles a month that we were traveling, because we were not automatically doing all of those in-person visits. Decreased a little more the first half of 2019 and 20, and that, that's good. We're pleased, but may not be that significant of a difference after that initial drop. Now, the fact that we have 0 miles so far in school year 2021 is really more related to the pandemic than it is related to the fact that we wouldn't be making any visits, because there are still some that we would do, but I would anticipate that this hopefully will get down to between the 200 and 300 range over the long haul, which is an amazing saving of resources, both time and money, because of the travel. It used to average, a school visit would average about 3 hours of time for the school liaison, and now it's about an hour and 15 minutes. So it has dramatically reduced both of those things. One of the last things I want us to look at is how school liaison time matched up with the level of need that the family was assessed to have. Certainly and you can see the minutes, the standard deviations are quite large, but and this is again preliminary data because we don't have all of the time data in. Some of it is we still don't have it yet. But there was significant difference in the amount of time required to serve low need families as opposed to the high and moderate. There was not a significant difference between moderate and high. So again, that leads me to that curiosity of where those families that score a 3 fit in, and how many of them might really be low and not need a lot of time beyond that initial contact. And then even, this is not broken into tier, but you can see that the difference in the amount of time over the year that a patient was in the study is tremendously different between a long-term patient and a newly diagnosed patient. So I think that these pieces of information will be helpful long-term as we begin to assess allocation of staff time. It'll be important to think about some of these differences. So we know that new patients were significantly more likely to have moderate and high school needs, and we know there was a significant difference in time required for the low versus moderate or high need students. So we could say that we certainly have been able to document efficient use of resources. Like I said, the reduction in the amount of time that a school meeting would take, the reduction in the amount of time that we're spending maybe with some low need families that we would have otherwise spent unnecessarily, and then the travel saving significantly. So some lessons and observations. Number one, don't try to collect research data during a pandemic. It's quite a challenge. It's really good practice to complete the BSNI at least once a year or at school reentry, especially for moderate and high need patients, because we want to see if their needs are fluctuating and manage that. Low needs assessment should not, or families should not need further follow-up unless you are alerted to a problem by either the medical team or the family. Overall, I think there is good support for using a tiered intervention system that's fueled by an assessment including the BSNI, because we know that not every family needs the full buffet of services. We really can target intervention and do so efficiently. The tiered intervention model does support the academic standards of care that have been developed. Standard number 11 is academic continuity and school reentry support. And certainly by using a tiered intervention system, you can see more families and justify the way that staff time is used to meet the higher need families' needs. Universal assessment identifies those needs. So once you have universal assessment, then you can go from there and use the tiered intervention model. If you haven't had a chance to explore the psychosocial standards of care and the matrix and the guidelines that go along with that, I would encourage you to do so, especially if you're just beginning to develop a school liaison program, or if you're looking to try to streamline your program, those guidelines can be very helpful. So in conclusion, I think we can say again that tiered intervention service model is doable and reasonable. It can be structured, I think, to fit the needs of any particular care center, large or small. The center would create the menu of services that are available, but universal assessment meets that guideline of psychosocial standards of care, and that is the link to help us move forward to better target our services. I do want to be sure to mention that there was financial support provided for the study by the Madding Miracle Foundation and also by Ohio State University Center for Clinical and Translational Science. And here are a list of references that I've either cited or you may find helpful. And my contact information, should you have questions or just pieces of this that you might like to just discuss, I'd be happy to entertain questions or discussion. Thank you very much for listening to this discussion of this program.